pretty much any tissue in the body can form a cancer, specifically cervical cancer. The cervix is the opening structure of the uterus, and that is made up of two different tissue types that cancer cells can arise from, either from the cells called squamous cells that are very similar to the skin on the outside of our body, versus the glands that line the canal of the cervix leading up into the uterus, and that can cause adenocarcinomas, or a different type of cervical cancer. Both of those cancers, about 99% of the time, are related to the human papillomavirus, the HPV virus, that can become incorporated into either the squamous cells or the glandular cells, and can lead to cervical cancer happening. Many times, cervical cancer is not symptomatic if we can catch it early. So that's why many women come in and they're surprised in some cases, because they're like, I had no idea that I had cancer. Mm-hmm. And that's because of the pap smear. Ideally, we are identifying pre-cancer of the cervix to prevent the cancer from ever happening. But if a cancer were to occur and it's early, many of the times there are not too many symptoms. If a cancer of the cervix has been there for a while and what we say is advanced stage, meaning it's grown locally there and has gotten larger, that's where symptoms can occur. And it's usually things like bleeding, pain with intercourse, abnormal vaginal discharge, and sometimes pain. But again, the hope is that we're catching it before it turns to cancer. And if not, a large sum of those women are not even symptomatic from it. It's something found on pap smear. It's diagnosed typically, ideally, it's diagnosed usually by biopsy to confirm. But to back up a little bit, back in 1975 timeframe is when pap smears became more readily available in the United States. And pap smears are like a mammogram or a colonoscopy. It's really intended as a cancer screening test, not to necessarily find the cancer, but to actually find something precancerous, right, to prevent the cancer from ever happening, okay? So as women are getting pap smears, those are taking samples of the cells from the cervix to identify precancerous changes, to then intervene medically to prevent it from ever happening and intervene. If we are in an unfortunate situation where somebody maybe hasn't been doing their routine pap smear surveillance, or a cancer is identified, usually on exam, it's either the cervix looks normal, the pap smear comes back abnormal, that leads to further tissue biopsies that finds the cancer. Or in cases where maybe it's more advanced, we're doing a pelvic exam, we go to collect a pap smear, but it's very obvious on exam the cervix looks very abnormal, and we skip the pap smear and go straight to biopsy and then confirm the diagnosis of cancer. I can honestly say that in the women's cancer world, especially gynecologic, if we just push breast cancer aside, very important, but if we just separate breast cancer out and talk about pelvic gynecologic cancers, there has been more change in recommendations for screening in cervical cancer in my career alone. I mean, it's hard to sometimes keep up with it, right? And this is this is affecting our primary care doctors and our OBGYNs that are doing these screening tests, right, before a patient gets to me. And as a specialist in cervical cancer, it's overwhelming sometimes to go back and try to keep up as it's been changed. And that's not a bad thing. The main reason why we've had that significant change since the 70s with pap smears is that not only did we have pap smears begin to happen, then introduced the concept of HPV. And when human papillomavirus was tied to the cause of the majority of cervical cancers, correctly so, there was a lot of research and information being looked at about how can we use information about HPV to not only prevent cervical cancers, but meaning could we treat it? Because, is there a way to treat the virus to treat the cancer? But then the second piece to that is, should we be looking at the presence or absence of the virus instead of just a pap smear? And that's kind of where the changing for screening has dramatically changed, including the most recent updates in 2020, last year. Okay. Mm-hmm. So not to complicate things, but I guarantee you there's a lot of people out there, primary care and OBGYNs, that are, again, since 2018, and it just keeps changing rapidly, that now the current guidelines stand, okay, that if you're aged 21 to 24, we should not be doing screening at all. Just to give you a comparison, prior to, we started screening when people became sexually active or around the age of 18, right? So that has changed dramatically. We want to hold off on screening women too soon, okay? So that's been a big change. So next thing is between the age of 25 and 65, okay, the current guidelines are saying that the first recommendation is not to get a pap smear every year, but it's to actually get tested for HPV every 5 years. Okay, so that's a game changer. That's very new. Okay. Yeah. If that's not going to be the recommendation, the next that's the preferred recommendation. It's acceptable to do HPV testing and pap smear every 3 years. That's option 2. Okay. The third is that you could do a pap smear by itself every 3 years. And I got it confused. Hold on. It's HPV test every 5 years. First choice. Second choice is HPV with pap smear together every 5 years, or pap smear by itself every 3 years. See, even me trying to go through it, right? It's new updates to try to keep it straight. Those are the recommendations. Well, as you can imagine, it used to be pap smear every year. Mm-hmm. Okay. And then it transitioned to pap smear. And depending on the results of the pap smear, then we took for HPV. There's just been a lot of dynamic changes, which can be confusing not only to the providers trying to provide that, but then to communicate that out to the patients, right? Yeah. But the bottom line is there are great screening chances or choices, available to us, right, with this new updated information to prevent cancer from ever happening. Right. So I think the goal is for women to make sure that they're establishing care with their primary care provider and OBGYN early. Okay. So again, around the age of 25 is when they're recommending to start. And again, for young women who are not yet 25, the guidelines could change by the time they turn 25, right? But then the next phase is for those that are 25 and older. If you're 45, you've probably been doing it very differently up until this point, right? But to touch base and have those conversations with your primary care provider to figure out what of those 3 choices is the most comfortable for you, okay? And then, but those are the most updated guidelines, but they have changed pretty rapidly over the years with this new information about HPV. I think the goal is we are not recommending women don't see their primary care provider, whether that be in younger women. It does tend to be more OBGYN that serves the dual purpose of being, our primary care provider for not just gynecologic things, but some of the other health maintenance issues that arise. Or for women as we get older, or I like to say less young, that may transition from OBGYN to a primary provider, or maybe you see both, right? That still should happen every year, without a doubt, because only one component of that exam is the collection of a pap smear or an HPV test for cancer screening, right? But at those visits includes exam to make sure we don't have any concerns about the uterus, right? Which is a completely different type of cancer, right? And workup. Feeling for the ovaries for evaluation of potential risk of ovarian cancer, right? So we should still be seeing our primary providers for all the other reasons. So to your point, it's not that they shouldn't go in every year, it's whether or not a test for cervical cancer screening needs to be done at each of those visits. At the beginning of the pandemic, this is unprecedented. We've never in modern medicine seen an experience like this before, obviously, to have to adapt. And there were clinics that were just shut down because we didn't know if it was safe or how to make sure to have enough protection equipment and for guidance. But once that initial, kind of situation, and we have testing available, we know a little bit more about the virus, et cetera. By all means, I think all facilities that I have participated in the healthcare, primary care, all the way up to the hospitals, have done an excellent job at adapting to making sure patients are being screened and, making sure it's a safe environment. And I do not want women to feel like they cannot go in and, get updated healthcare maintenance. I really recommend they resume those visits with the guidance of their primary care providers and OBGYNs, as they have outlined those recommendations to keep them safe. So HPV is known to be in the majority of cases is the underlying cause for cervical cancer. There are well over 100 different types of the HPV virus, papillomavirus. Only about a quarter to a third of those have been identified in the female or male, to be technically, correct, reproductive tract, okay? Of those types or the viruses, they're numbered like 1 to 16, 18, 11, they're assigned a number. Of those group, there's only about 15 of those that have been identified as high-risk HPV subtypes, okay? And they put those in those categories because it's those high-risk types that have been associated with causing cervical cancer, okay? And again, a whole other conversation is vulvar cancer and vaginal cancer. That's for another day, right? But at least we're just talking about cervical cancer that have been associated with causing HPV. So part 2 to that is that HPV is a sexually transmitted virus. Okay, that's how we believe the majority of women get exposed to HPV and the reproductive tract. Okay, so HPV, many women and men, we believe 80% approximately, will have been exposed to HPV, one or multiple types, in their adult life if they're sexually active. Okay, so it's more common than we think. It sounds scary, right? But I don't want to cause people overly concerned that HPV is out there. It's present. We are most concerned about the high-risk types in this setting, talking about cervical cancer. So in this setting, I guess the first easiest version of that is to say you can reduce your risk of getting cervical cancer if you're not sexually active, right? Now, that's a choice, but definitely not an ideal one for most people, right? In their adult lives, in their relationships, if they want to just be in a relationship or have children, et cetera, right? So in that setting, the more partners we have sexually, obviously, increases the chance one gets exposed to more types of the virus, and therefore increased chance they get exposed to the high-risk subtypes. So yes, I think it's very reasonable we can be sexually active and responsible about it. Reducing the number of sexual partners is obviously a component to that, okay? And then understanding that once we have HPV, we used to think we've always have it. It's in your body, you'll have it forever. We have since learned that you can clear the virus from our systems, but understanding that one of the reasons why high-risk HPV is more likely to cause cancer is it tends to be HPV of those types, for some reason, is harder to get rid of, right? Our immune system or whatever factors are involved can't get rid of it, hence one of the contributing factors for it to be high risk. So once we have it, though, then the next question is there anything we can do once we get exposed to prevent it getting into our tissue and staying there, like those high-risk types like to do? Or is there anything we do after exposure to help our immune system get rid of it? Enter the concept of the vaccine, okay? Mm-hmm. So the vaccine became part of it 10 to 15 years ago, where to say, vaccines are meant to, just like COVID, right? The idea behind the virus is if we can get a vaccine that if we get exposed to HPV through sexual contact, can it help prevent our bodies from getting it into the tissues and staying there, including the high risk types, right? And the vaccine has been found to be highly effective at doing that. Okay, so I recommend people get the vaccine to help reduce the risk. The whole question about whether or not we've been sexually active, we've already been exposed, particularly to the high risk one, will the vaccine help our bodies get rid of it? That's a different question, and that has been less helpful, right? Once it's there, right? The vaccine has not yet definitively proven that it helps our body get rid of it. There are some studies that show maybe it will help reduce the risk of it causing trouble down the road, but that's not its current recommended use. So the best thing for women to do is, before we become sexually active as adults, is to get the vaccine. It is FDA approved at the age of 9, as early as 9. The CDC tends to recommend aiming more towards 11 to 12 years if possible, but you can get it up to the age of 26 is the current guidelines. Okay. Whole other discussion about use after that, which is, again, another day, but that's the idea, to get it before sexual activity onset to reduce the risk of it in becoming part of our tissues and not being able to get rid of it and causing issues. Same concerns people have about vaccines in general, meaning people worry about maybe side effects, allergic reaction, right? So just like the current vaccine out, there's components of the vaccine that they would review with you. And if you have any history of allergic reaction to those substances, you shouldn't get the vaccine, right? But in the majority of cases, this is built very similar to the hepatitis B vaccine and, things like that. It's been a very safe vaccine. And there have been no reported major issues with that vaccination. Okay. So people fear reactions to it. We don't tend to get the side effects of like the flu-like symptoms or, some of those that you get with the flu shot and maybe the COVID vaccine. And it's interesting, there are studies that show, again, if you're doing the vaccine early on, right, you're dealing with, young children who might not like shots. Well, maybe more adults, we don't love shots either. But again, some of that, the immediate, concern is that, of course, it hurts and you're not sure what to expect. But again, the pediatricians who have been doing vaccines forever, I have no doubt do a great job at, helping facilitate those conversations between the kids and their parents during the administration of those vaccines. But they've been very safe. In general, risk factors, because of its association with acquiring because of its association with HPV virus, and therefore the acquiring of the HPV virus, multiple sexual partners, as we mentioned before, increases your risk of cervical cancer because it's increased your exposure to high-risk subtypes of the HPV, okay? The additional things that we have identified is that you have increased risk if you are a smoker. And many people are like, well, how does that make sense, right? Is that my doctor giving me one more reason to make me feel bad about smoking, right? Because you're like, what is, we know lung cancer in smoking, but what does that have to do with cervix? They've done studies that have identified that, again, the tobacco toxins accumulate in mucus secretions in the body, and cervical mucus, they've identified tobacco toxins, and they believe that has an effect on, I don't know, I kind of think of it as, is our immune system trying to fight out the tobacco toxins present, or somehow how does it affect our immune system's ability to deal with the HPV in the cervix to prevent it from doing something and causing precancer or cancer. But it's been a proven entity that those smoking dramatically increases risk of women having precancer of the cervix and therefore cervical cancer. And there's biology and science to prove it. It's about the tobacco component of it. Okay. The other one is other patients who are immune compromised for other reasons. So HIV, AIDS, other immune disorders are probably less proven, but again, that can include things like being an organ transplant patient, where patients are on medications purposefully to blunt their immune system, right? Because of their transplant, well, they have a higher risk of having HPV-related disease as well, again, because of that immune component of it. Another component you can see is women who have other sexually transmitted diseases, including or more notably like herpes virus, genital herpes, have a higher risk of HPV related disease as well. Again, maybe that concept that the immune system is fighting off more than one thing at a time and is less able to keep at HPV in check. I guess we should say this. You're tested if you follow the guidelines and you get an HPV test, and then you are sent in with a high-risk HPV test. Again, typically things start with screening. Who could be at higher risk, right? And then you have to get to an actual tissue diagnosis. Many women have heard the term colposcopy, right? Colposcopy is the procedure done in a clinic, most cases, where we are using a almost like a microscope in a way, right? A better visualization of the cervix. And we use different techniques along with that to help tissue along the cervix, help us see it better, to identify areas where there possibly could be something going on. And then again, but cervical cancer is or has to be diagnosed by an actual tissue biopsy. Mm-hmm. So if it looks at, we're talking microscopically, those are going to rely on small biopsies or scrapings or things like that, versus, again, you go in and the tumor's been there for a lot longer and it's past the point of pap smear. We can see a tumor. We still need to biopsy and get that tissue confirmation. Once a cancer is diagnosed, in the next phase, there's a lot that goes with that in a broader picture, okay? What happens at that point is once we have a cervical cancer diagnosis, that's where we enter as GYN oncologists, okay? And then starts the whole question. It's probably one of the most complicated, complex structures to determine for a couple of reasons. One is, again, it's happening in our reproductive organs, and where is there a role for potentially treating the cancer if it's early enough and maintaining a woman's reproductive capabilities, right? So that plays in and can make a lot. And those are options that can happen in certain cases, but definitely not all cases, right? If we just move the potential for can we or can we not save a patient's ability to carry a pregnancy, or have a genetic, save eggs for a genetic reproductive process where they can have a surrogate carrier or something like that. If we just, which I don't mean to minimize, if we just set that aside, the treatment for cervical cancer can get complex in and of itself. If it is super early, lack of a better way to put it, right? Regular hysterectomy, okay? Routine removal of the uterus, cervix, and fallopian tubes, and keep your ovaries in place for hormone production, right? That's the minimum intervention to cure cervical cancer that is early. Then it jumps to something called a radical hysterectomy, where again, we are removing more than just the uterus and cervix. We remove the top of the vagina. We're removing tissue around the uterus and cervix to get margins or more tissue, and then sampling lymph nodes to make sure that those don't involve cancer. And then as soon as we jump from that, those are still stage one. Those are both stage one cervical cancers. As soon as we, get to the end of stage one, some of stage ones and on down, we go straight to radiation treatment, right? So it can get more complicated as we go through. Still curable, but now we're out of the surgery realm, even in early stage disease, and we go straight to radiation with or without chemotherapy at that time. And not to complicate things, cervical cancer that's metastasized or spread already when we find it, sometimes we start with 3 chemotherapy agents with or without radiation treatment after that. So it can get a lot of different steps. Clearly, the whole point of this, though, if women are doing their surveillance, is that most of them, obviously, if we're doing our HPV testing or our pap smears or whatever choice our primary team is following with us, we are hoping to capture it well before it turns to cancer. Again, just to stress it, because it's very preventable. Cervical cancer is very preventable if we follow those guidelines. But if it happens to be cancer, we're in a realm where we're trying to minimize the intervention to get the cure. Yes and no. So okay. that is interesting. The way it depends on how you look at it. cervical cancer right now worldwide is the #1 diagnosis of cancer women die of worldwide. It is the most common cancer in the world, okay, for women to die from. In the United States, it's plummeted down that list because of the pap smear in the 70s. So we saw the incidence of cervical cancer in the United States took a nosedive around that time frame because we had a screening test that was applicable, okay? So you have to have access to healthcare, access to pap smears, access to people who can read the pap smears, let alone all the HPV testing and typing that is now overlapped, right? And we can all think of many places in the world, right, where access to healthcare is a hard stop already, right? And so that women don't have access to mammograms or pap smears or things like that, which is why it tends to be so common still, or is the most common cause of death from cancer in the world still. Now, in that setting, though, in the broader picture, I mean, there is a lot of work being done to try to, prevent it and intervene and et cetera. But the other piece to that is the average age of cervical cancer is younger than most other cancers too, okay? So even in the US, we tend to see more cervical cancers mid-20s to mid-30s age range, right? So if you can imagine worldwide, if women get cervical cancer first before they would ever get breast cancer or colon cancer, right? It's another reason why you see it more prevalent in the world, because it causes cancer, the incidence is much younger in our lifespan as well. So, but we have done a significant reduction, or seen a significant reduction in the United States, but that's not the case worldwide. In the preservation of fertility, again, as you can imagine, if already in stage 1, we've jumped from regular hysterectomy to things like radical hysterectomy, the concern is leaving enough cervix where the cervix can still close during a pregnancy and stay closed for the gestation of 9 months, as close as possible to carry a pregnancy successfully. So there's that question. There's the concern about metastasis. So is the cancer somewhere else already when we find it? And what's the risk of not removing those tissues to make sure before we perceive, right? So there has been a lot of work to try to make sure that the mom is safe, that we're curing the cancer and not putting her life at risk, while still trying to preserve that very important question about fertility or conservation of fertility. So there are times, and again, where if it's early, there can be local excision, typically called a cone or a leap excision of the cervix, and that can be monitored very closely. There are times where trachelectomy, where the cervix itself can be removed in its entirety. That's a whole other conversation, because again, if you can imagine, if that's an option to cure the cancer but keep the uterus, that pregnancy, if a woman goes on to get pregnant in the future, is not an easy pregnancy, right? And many times is not a successful outcome, okay? Because you have to do a procedure where they have to stitch the uterus closed during the pregnancy called a cerclage. That's at risk for preterm labor and delivery. There's a lot that goes along with that. But please know, I mean, there is focus to try to do what we can safely to maintain in certain situations. And we have very lengthy discussions with patients who are in that situation to determine the balance of safety for their overall health versus the ability to try to maintain fertility options. I should also mention that as part of this is sometimes when we know we can't do more limited surgery on the uterus or cervix, is also introducing concepts of, can we get them in to get ovarian tissue harvested or eggs retrieved from the ovaries, so that again, even though they have to go through a bigger cancer treatment and they won't be able to carry a pregnancy, could they have a surrogate or other options down the road? We look at that too as a component of all of this to look at fertility conservation for patients. we do have to take that time, absolutely, to kind of have those conversations, because it can get really complex. And please know, with this, there's extra imaging, and there may be additional, I mean, there's so many other little details behind the scenes as we're taking care of a patient maybe considering fertility, or even for the patients who are not doing fertility conservation, we're still doing those extra steps along the way as we make those treatment plans. A lot of times, most of those trials are only for patients who are advanced stage at the time of diagnosis, where we're talking chemotherapy, multi-agent chemotherapy with or without radiation, because a lot of the ones we're preventing, or they fit in the category which have cure rates 90+%, right? So there aren't many studies that are trying to focus too much more on that at this time, because we've got great success rates, right? So a lot of times trials enter where there's less known answers, right? Or it's harder to cure, or maybe not able to cure in some situations. And so the studies in cervical cancer do tend to center more around those advanced stage cancers, okay? Or in cancers that recur, come back down the road. And most of those have, they're talking about drug therapy. So different chemotherapies, or now there's new studies looking at other drug groups like gene targeted therapies or immune therapies, but there are studies available. It's interesting though, it's harder to open up trials sometimes in cervical cancer. One, the cancers are more rare, okay? Again, as we said, in the US, it's more rare. So it takes longer to get enough patients that would meet trial, that would actually be able to be on the trial, to then complete a trial in a reasonable amount of time. It takes 10 years to complete a trial. We've moved on, right? It can be harder to do trials. So that is a limiting factor sometimes as well. And for a good reason, I guess. I mean, I'm glad we don't have that many women that fall in that category, but it can be a limiting factor with cervical cancer. Our focus is anytime where there's a trial available, it goes in our conversations in cancer of, these are the options on the table, of which include, if there's trial eligibility or availability, absolutely. There's a couple of things just to point on. One, if we get vaccines, if we're vaccinated, again, as early as 9, right, up to 26, if we receive the vaccine, okay, that does not mean we should not get screening, okay? So the vaccine, there's different versions of the vaccine, but none of the vaccines out on the market cover all of the high-risk subtypes that cause cervical cancer, okay? So the guidelines aren't get vaccinated, don't get screened. It's get vaccinated, still screen. You still want to do that. It does not negate the need for cancer screening, okay? Now, as things evolve, things may change, right? It changed dramatically by 2020, but at this point, vaccination does not equal don't need screening. And sometimes I think that can get a little confused, because we think about that as I'm protected. You're protected, but it's not a guarantee, okay? It just significantly reduces your risk. So I do want to make that point. You asked that really important question about, do you still need to go see your primary every year? And that was a great point too. But for the same reason, you get the vaccine, should still be screened. The next thing is I did mention girls getting vaccinated, but please know the current guidelines recommend boys get vaccinated as well, right? So if we acquire exposure to the HPV virus through sexual activity, that's the majority of time where we believe we get exposed, low risk or high risk, but definitely the high risk subtypes, again, that should also include male partners, right? And so the guidelines were updated that boys also can be vaccinated as early as the age of 9. But again, the goal age is still around 11 to 12 if possible, okay? But as far as vaccination, that's important too, because then we're reducing the exposure for everybody, right? So if the boys have been vaccinated, less likely HPV stays in their tissue, less likely to be exposed, exposing others. So I'm an advocate for that as well, to remember that this isn't just the responsibility for us as parents for our daughters, but also for our sons. Even though their risk of getting cancer from HPV is not as high, or it's different than it is in girls, it's still very important that they get vaccinated as well. Talking about cervical cancer is incredibly important. I think, because we don't see it as much, whatever, patients can feel very alone in this diagnosis, and you try to go online and read about it. It's confusing. It really is, for a lot of reasons, right? And including the complexity, I just very glazed over, is just the all the details involved in treatment. But number one, it's preventable. It is very preventable. So advocating for women to make sure that they are talking with their primaries, updated guidelines, coming to a discussion based on, what they're comfortable with, but making sure that we're taking good care of them and asking questions. We can prevent this one so much better than we can so many other cancers I treat, right? And that's where I think the emphasis needs to go, so that we can, continue to drop cervical cancer incidence in the United States lower and lower, right? As we move forward. So it's the prevention component that is so key to this.